Good morning to everyone. My name is Sivasuthan. I'm attached to Counties Manukau, a full-time ophthalmologist at Manukau Super Clinic and Middlemore Hospital. We have some clinics as well. So thank you for inviting me to talk on this topic, a few topics which was given. One of my colleagues was, in fact, was taking some of the topics, but unfortunately he's on leave, so I have to take 3 topics. So hope you all put up with me for all 3 topics because I had to rush through. So the surgical day, I was thinking whether it is really surgical, but certainly there's a surgical component of this condition, so that's what I thought. So first we'll start with the flashes and floaters. You all come across, I'm sure everyone would have come across patients who complain of flashes and floaters. And what is important in this one and what we have to do when the patient come to you and what not to miss. So these are the important things and mainly to refer when. So when you look at this diagram or the pictures, you can see the what is on your right, where these floaters are. These are particles floating in the vitreous, which causes cast a shadow on the retina. So that is how important it is, right? By looking at the next diagram, you can see that it is associated with retinal detachment. So that's the main thing, because it's a blinding condition, retinal detachment, if you don't attend on time. So that's the reason we have to act on time. So how do they describe various shapes and size of floaters people can. The typical one, they complain as a ring, a complete ring. So that if I go back to the slide, so here you can see, sorry, I don't have a, but probably you can see the vitreous attachment to the optic disc. When it moves forward, it makes a complete ring. So that's what people complain of, a complete ring, or it could be of any shape, can be flies, cobwebs, worms. These are very prominent, especially when they come to, when they are in a clear background, not very bright, but well-lit, clear background. You can see that very clearly. That's a common complaint people come with. If it's due to vitreous hemorrhage, that's the other important condition to know, can present like a floater. Probably you would have come across patients with diabetics, suddenly they say, okay, I see a dark blob when I woke up, it is sort of floating around. Or it could be just small particles of red blood cells, either way they can present. Then the other associated condition with floaters is the photopsia. That is a visual phenomena where you don't get any light stimuli or source, but still they complain of, say, in the form of a lightning or camera flash. So mainly they complain in the temporal, but not necessarily always temporal, but can be anywhere in the visual field. These are very momentary and can be confusing also, because people sometimes confuse with the migraine aura. So how do you differentiate that from? So normally migraine aura, sort of a continuous, it's not very momentary thing, and there's a particular pattern you see in migraine aura where you get a zigzag type of shadow starting pretty closer to the mid visual field and moving away from that. But here it is a very bright flashing of lights, so generally you can differentiate that way. And also this can be simulated by movement of the eye, or if the patient start moving, then you can see more flashes. So why do we take or give much importance to this PVD? Because if you in a way it's common, because if you remember simply 65 years old people, if you look at about 65% of them will have floaters, right? So PVD, it is associated with retinal tear, especially in those who are having predisposing conditions of either previous trauma or inflammation or any injury in the past. So what's the incidence? As it is mentioned here, it's about 14% of PVD associated with tear. And so the tear means the retinal breaks I am talking about. So if you take the people more than 10 years old, you can see about 6 to 14% of the people will have these retinal breaks. But whether all of them develop retinal detachment is no, but certainly we have to, assess who needs treatment and who don't need treatment, especially if the breaks are circular and without any flaps or any existing vitreous attachment, then you don't have to worry too much about. So all those things has to be decided by an optometrist or an ophthalmologist. So try to refer if there are any warning signs like what we spoke before. So these about a third of them, these PVD with tears can develop retinal detachment. This is more so when you have the retinal tear. Chances are more when there's a hemorrhage, because people can suddenly develop photopsia and a large blob floating in there. So that shows there's a hemorrhage associated. So that gives more chance. So that has to go a bit more earlier. And if we all talk about this retinal detachment, it's not a common condition again. If you look at the incidence, either 12% per 100,000 or 1% per 10,000, you can call it that way, right? Okay, so pathophysiology, it's a age-related changes where you get the degenerative changes, which happens in the posterior part of the vitreous. If you look at, sorry, I'll go back to the previous one. It happens in the back part of the, the vitreous, and the solid part still remains in the front and clinging onto the front of the retina. So that's how every time it moves, it has a energy or kinetic energy. So that pulls the retina, causes the flashes and then the floaters. So the degenerative condition, but which can which actually has a condensation of the collagen fibers and can be associated with infection or inflammation or hemorrhage, then it becomes more obvious or more prominent. So we take a history, especially if it's a recent onset, then please refer them for an acute assessment, because the early assessment is important. If that is missed, of course, then we are missing what we are going to, as an important condition. So when you send them to optometrist or ophthalmologist, they can examine and they can see tobacco dust, so hemorrhages. The peripheral retina will have retinal degenerations, holes or tears, and of course, retinal detachment also may be there. So that's the main reason that we worry about posterior vitreous detachment, because that's the commonest cause to cause flashes and floaters together. So management, say flashes and floaters, just a warning, you ask them to check regularly, each eye separately, that's important. And say if the symptoms of flashes or floaters getting worse, or if their peripheral vision shows shadows or sudden drop in central vision, those are important things to refer immediately, or within hours or same day. So what they can do, ultrasound, if the media is not clear, if there's cataract or for any other reason, if the cornea is not clear, then they can do ultrasound or OCT to diagnose other than the direct frontal examination. So just to see what they do, there are PVD and retinal. So you don't have to do any treatment as such, but there are laser treatments available, which is not very popular though. About 50% of the patient with laser treatment, they can improve symptoms, but still they can continue. So that is recently like what we do, YAC laser, the similar machine, you can do the laser treatment. Then when they associate with retinal detachment, of course, you have to fix that, the PVD with retinal detachment. If the macula, the outcome depends on if the macula is on, there's a good outcome. So that's what we expect to be referred as early as possible so that, the outcome is good. If the macula is off, then patient's outcome will be limited.